Well, I hope all of us had a chance to read the articles that I posted, because you see, when you come for Journal Club, it's good to come when you're already informed, because it's supposed to be a discussion. So in case some of you did not get a chance to read, I'll just give a quick summary of the article that I had posted. So we all know that Burkitt's lymphoma is a B cell lymphoma, which is common in the pediatric population, but it also affects adults. And there are three main kinds which are recognized. We know the sporadic one, and then the endemic one, which is more common in Africa, and the one which is immunodeficiency associated. So usually for Burkitt's, the commonest protocol is the R-CHOP, which we all know. And then there's a new one, which is considered first line, which is known as CODOX-M. It's given alternating with another one called IVAC. So the purpose of this journal club is we are going to discuss another one called R-EPOCH, which is a first line regimen, which has not yet, it's not commonly used. Most people are still using CODOX and CHOP. So I'll start. Oh, okay. Okay, so that is what I had said. Okay. So the article that we are discussing was published in the New England Journal of Medicine in 2013. The reason they decided to do this study was because they noticed that the current protocols in use were very toxic for adults. Like, they were working in the pediatric population, but for adults, they had a lot of toxicity. So they decided to see if they can find a less toxic regimen. So this study was carried out from November 2000 to December 2009. The study design was prospective, and they had several endpoints. The first one, they wanted to find out what was the rate of complete response in their patient. They wanted to find out the time to progression and also the treatment toxicity. So the patients who were eligible for the treatment had to have Burkitt's lymphoma as a diagnosis. The patients had not received any chemotherapy prior to being enrolled in this study. They had to have all their organs functioning at optimum levels. That's like the UECs, LFTs, CBCs, all had to be normal. And then no pregnant women were eligible for the study. And then prior, they also did CSF studies, the cytology, to make sure that there was no infection. And then they also did a CT scan for the brain for imaging. So the patients who were enrolled, they ranged from the age of 15 to 58 years, with a median age of 33. And there were 30 patients. So 19 of them were HIV negative, and 11 were HIV positive. And out of those patients, we had 17% who had low-risk disease, and 10% who had high-risk disease, and 73% had intermediate risk disease. And all of them received the R-EPOCH. The only difference was that for the ones who were HIV positive, there was dose adjustment which was done. And then for the ones who were HIV negative, there was no dose adjustment, but they got a double dose of rituximab. Not HIV negative, got a double dose. The ones who were positive, there was just dose adjustment which was done for doxorubicin and cyclophosphamide. Okay. So the other difference was that the ones who were HIV negative got 6 to 8 cycles. The ones who were positive got fewer cycles. Those were 3 to 6. And then also the HIV positive patients did not use their antiretroviral treatment during the chemotherapy. So for supportive care, they used hydration and allopurinol to prevent tumor lysis. This was given throughout the chemotherapy period. And then they also gave intrathecal drugs. So the way they were giving the intrathecal drugs depended on whether the patient initially had CNS disease. So as you can see there, the ones who had CNS disease, they were given intrathecal medication twice a week for 4 weeks, and then once a week for 6 weeks, then once a month for 4 months. And the ones without CNS were given on the first and fifth day, 3 weekly. That is beginning from the third cycle, and in total they got 8 doses. And then they also got filgrastim, which was given for each patient, that is from 24 hours after the chemotherapy up to the 5th day post-chemotherapy. And they used the absolute neutrophil count to adjust the dose of the chemo in the negative patients. But for the positive, they were not using it. So even if a patient had neutropenia, they would still continue with the same dose for the chemotherapy. I hope you've all understood. Okay. Yeah. So for the side effects, the most common was fever and neutropenia. This was reported in 22% of the patients. And it was noted that the ones who were HIV positive had less complaints of fever and neutropenia, and also in the older age group. And thrombocytopenia was noted, but in just 2% of the patients. For tumor lysis, it was noted in just 1 patient. And then they noted that the CD4 counts had reduced pre and post-treatment. So for the outcome, there were no treatment-related deaths. They did a follow-up. For the HIV-negative patients, it went on for 86 months. The event-free survival was 95%. That's for the negative patients. And the overall survival was at 100%. And for the HIV patients, the follow-up was for a shorter period, that is 73 months. And the event-free survival was 100%. Overall survival was at 90%. So there was just 1 patient who did not achieve a complete response, and that patient got radiotherapy after completing the chemo. And then we had acute myeloid leukemia, which developed in one of the HIV positive patients 2.5 years after the chemo, and that patient died 4 months later. So when you read the discussion at the conclusion of that study, they noted that, and also if you read the other articles that I had posted, you know that Codox M IVAC is very toxic. Its most common side effects are neutropenia and thrombocytopenia. In fact, neutropenia, it causes it in 90% of the patients, and thrombocytopenia in 58% of patients. And then it also causes some mucositis. So, and the general outcome in some studies which was done were an overall survival rate of 69% at 2 years, which you can see is less when you compare to the R-EPOCH, which we've just talked about. And then for R-CHOP, it's a low intensity regimen, like it's not toxic, but the survival rate is less than 40% in adults. So up to now, there's no direct comparison which has been done between the 3 regimens, meaning like there's no trial which has enrolled patients in the 3 different regimens and compared the outcome up to now. Yeah. So now we are going to discuss, now when we take into account the outcomes and the toxicities of CHOP and CODOX, can we agree that R-EPOCH is an alternative which we should consider in our setting? That is the question that we are to discuss. Yes, double dose of rituximab. Yes. Epoch. Yes.
Got it.
Oh, sorry.
Yeah.
So we have
Jesus, we cannot hear you.
these two groups of adults, and which typically represent the kind of patients we see here with the buckets. Some have HIV, some do not have HIV, and so the question then is, I was hoping Dr. Njuguna would be here, even though this is mainly adults, but he would have given us what are our response rates at the moment among the patients we are treating with buckets, and exactly what regime are we using at the moment here for buckets. I think we need to understand that bit first before we discuss the epoch regime, because this is the dose adjusted epoch is like a second generation epoch, and then the dose adjusted double rituximab regime is like a third generation epoch regime. So uh, and for you to give epoch, you need 4 days of continuous infusion. You need a chemopot so that you can give these patients a 4-day continuous infusion. So we needed to look at, do we have anybody in the room who is currently treating buckets here? Maybe this can tell us exactly what regime we are using at the moment here. What is our first line for buckets here? And what are the challenges we are seeing? And what are the outcomes? Do you have any idea?
So we've done CODOX and IVANC. So when we reach the IVANC part, then so we have moved back. We are now doing CHOP. I think we have how many patients now on CHOP? 3 of them on CHOP. Yeah, and since that is what we feel is most comfortable, we have less toxicities, but we also know we are anticipating relapse. There's a young man who did well on CODOX IVANC, though we've lost follow-up. I think maybe because he was young, he was 16 years of old, 16 years of age. I don't know if he has a robust bone marrow. Yeah, so he actually did up to the third. He did CODOX, he did the CODOX, IVANC 1 and CODOX. He didn't come for the IVANC, but he actually did very well. So we lost follow-up on him, and we hope he's doing well. And then the other challenge, what that we actually the patients that we lost were immunosuppressed. Yeah, so we don't know whether immunosuppression played a role. I'm seeing here they actually there are patients who are who had the HIV were not getting their ARVs as they're giving the chemo. So I think probably for the immunosuppressed patients, there is already a bone marrow which is already affected by immunosuppression, and then we are going to immunosuppress again. So I think we can also have impact on the long term. So yeah, that's where we are, doctor. We are doing CHOP.
So at the moment we are doing CHOP, not RCHOP.
While now we are having challenges getting for those who are able to do their CD20, we are actually doing RCHOP. Yeah, but we at the moment our immunohistochemistry, we are not able to do the IHC unless I'm able to go to one of the private labs. Yeah, but I think rituximab is becoming more and more available, and actually we are pushing patients to do immunohistochemistry.
So I think the challenge we are having now is that we are unable to implement the first regimes for Parkinson's lymphoma in adults, which is mainly, CODOS, or hypersevered. I think that is where we have a challenge, that we are unable to implement them because we lose these patients at the induction stage, isn't it? That is really the problem that we are having. And so the question is, of course, epoch on its own is very toxic. Is even more toxic than the first lines that we are unable to do. But those adjusted epoch then becomes much more friendly because you individualize treatment. Therefore, you are able to escape most of the toxicities. Those who can tolerate, you give them what they can tolerate. It's like everybody for his own portion. Some kind of individualized treatment, which I think could be very, very attractive. And so the question is, what are the practicabilities of us implementing a 96-hour infusion of a mixture of vincristine, doxorubicin, and etoposide, because those three, have to be mixed together and given as a 96-hour infusion. I think if we can go around in terms of all the patients in this study had chemopots, and all the patients in this study actually who had CNS disease had Ommaya reservoirs for intracranial treatment. So people are not struggling to do LPs, okay? So it made life much easier. So Dr. Beatrice, maybe you can tell us how close are we to getting all our Burkitt's lymphoma patients with chemopots and those who have CNS disease with Ommaya reservoirs?
I think, well, in Eldoret, I've only seen it in private practice. They have the expertise, have the surgeons who can actually put chemopots and put Ommaya reservoirs, but I think the logistics within, maybe because we push the treatment. We will not start treatment until you probably do a chemopot for us. We might be able to start our patients getting those appliances put in there. So the patients who have chemopots here either were inserted on but I think it's actually possible. They are there in the market and we have the expertise. So
We can see.
Go through mute, please.
The echo is coming from your side.
Okay, thank you. I think most of these patients getting this intensive treatment should actually get chemopots, and it's possible. I don't know the cost implication here, but we should be able to do that as part of the surgical package for cancer patients. The second thing which I was wondering, why did they do double dose for HIV positive patients? Double dose of rituximab. Was there any justification? Because it's an expensive drug also, so it will have an impact.
Yeah, thanks, Dr. Parker. So the role of rituximab in in patients with HIV positive lymphoma is debatable. Okay, there are studies which actually showed that rituximab did not add benefit. Then there are also studies which showed that rituximab was very beneficial. And then the theory was, if they gave a double dose of rituximab, that would reduce the total number of cycles of epoch. So if you look at the initial studies on rituximab in HIV in the early 2000s, that theory came up, and actually they were able to demonstrate, the original studies on double dose rituximab are published in Blood, and you'll see fairly good responses which those particular groups showed with rituximab, and then they came up with this theory of give rituximab before starting chemo. It was actually in diffuse large B-cell lymphomas in patients with HIV before it spilled over to buckets. So it was give rituximab day 1 before you start chemo, and then give rituximab day 5, the same dose before you give cyclophosphamide. And they were able to show benefit out of that, because the idea was to reduce the overall number of cycles of dose-adjusted epoch.
Dr. Mwiriri, I don't know if you can be able to hear us from Aga Khan.
Yes, I've been listening to the discussion. I just want to kind of reinforce what we discussed earlier and what some of the other people have said. I think that some of the protocols are very, very toxic, and they might be prohibitive in fact, they are prohibitive in areas where we don't have adequate support, because it's well and good to deliver the chemo, but if you can't support them through the cytopenic phase, then you will lose the patients. So I have given hypercvad and R-epoch with a peripheral line. It's all patient dependent. And I have had the patients come back with neutropenic sepsis and treated them fine. I think these are things for planning. If you have a patient with good access, you can delay a long line insertion, you can delay a chemo pot insertion, because these come with their own complications with time, right? But that is all dependent on the person doing it. But the thing I would want to underline is we shouldn't deliver toxic chemos if we can't support them. So maybe we need to bear down on your transfusion services. You have to highlight that we're giving chemo for which we can anticipate patients will have thrombocytopenia that could be life-threatening. Therefore, we need to have a supply of platelets, please. Because if they're making blood every day, then they can make platelets. It's as simple as that. Then the other point to make is, oh gosh, it's gone out of my head now. But that's basically the take-home point. Oh yeah, the other point to make is, if we can't do supportive care, then perhaps you can accept the cost, but give GCSF in a timely fashion. Give GCSF on day 6 and continue to reduce the duration of cytopenia and the complications associated with that. Because there is a cost of the GCSF, but there will be a cost of the platelet transfusion and the red cell transfusion and the admission of the sepsis. So you have to balance those costs between themselves. If you're going to shorten the period of neutropenia by giving them 5-7 days of GCSF, then you might avoid a transfusion, you might avoid an admission to hospital. So those are also considerations. And as we said, with each subsequent course, your bone marrow becomes less quicker to recover, and so your needs increase later on. Personally, I do use our epoch for Burkitt lymphoma, dose-adjusted epoch for HIV-related Burkitt, and I have used hypercvad for ALL patients. But I think not only am I the hematologist, I also have a stake in blood bank, so I can be quite prescriptive on what I need. And perhaps you need somebody who can have a close relationship with the blood services and emphasize the importance of this, because there's no point of us being able to give the chemo if we can't support them through the complications of the chemo.
So Dr. Mwiriri, now that you are from Aga Khan and you have experience with all the 3 regimes, hypercvad, dose-adjusted, R-epoch, and I don't know if you've used dose-adjusted double R-epoch. From your experience, which of those regimes did you find most toxic? Because that is the...
Sorry, I missed the first of your question. Sorry.
So I'm saying this study is best...
The line was not very good. The first part of your question.
I see. So I'm saying this study is essentially based on reducing toxicity. And the selling point in this study is that
Yes.
dose-adjusted epoch and double, short course epoch with double rituximab are more efficacious and less toxic than hypercivard and Codox M. That is the main issue in this study. Would you agree with that?
Yes.
Would you agree with that hypothesis from your experience?
100% agree that Codoxem IVAC I would consider the most toxic of the three, followed by hypercivard, followed by dose-adjusted epoch. And to add to that, actually what we do, the Vinc mix, actually I do it every 24 hours. So they make it up for 24 hours, run it for 24 hours, then change it after 24 hours. So it's not the same bag running for 96 hours. So it's 3 24-hour bags or 4 24-hour bags. Does that make sense?
Yeah, I think that makes sense. And you mix the vincristine plus etoposide plus doxorubicin.
Yes. And then every 24 hours, run it for 24 hours. When it runs out, put the next one up.
How many mLs of fluid do you use, and which fluid?
1 liter. 1 liter.
1 liter of which fluid?
Normal, I think normal saline. Actually, the New England paper has an appendix which prescribes exactly how they did it.
Are you using infusion pumps?
So actually, we don't have enough infusion pumps. They're all taken up in NICU. So the nurses are able to count the drops and so that they run out after 24 hours. So it's not an exact science, but it doesn't mean you can't deliver the drug safely.
I think Dr. Njiru has a question.
Yeah, Dr. Njiru has a question and a solution to chemopots through NHIF.
Yes, I think we should explore NHIF for chemopots. I have a patient that was fixed in this hospital. So maybe we just need to be aggressive and make it possible for our patients. I'm just wondering for how long you've been doing this therapy with R-epoch. For how long, and what are your endpoints? Is it overall survival or how many years or how many months of survival of your patients? And how many patients do you have currently on that treatment?
Is that question to me?
Yes, that question is to you. You are the hero R-epoch is concerned.
Okay. So actually, at the moment, I only have 1 patient on R-epoch. I've only been working in Kenya for a year. So I only have 1 patient at present on R-epoch. And I have also 1 patient at present on hypercivard. She's and both are doing very well. Okay. In the past, I have used both regimens multiple times, but not here. It's difficult to tell you about long-term outcomes and overall survival without formally testing it or recording it. But what I will tell you anecdotally is for sure, Codoxem IVAC is way more toxic than hypercivard in my experience. Hypercivard I find quite manageable because you can anticipate things. You can anticipate when things are going to happen and mitigate for them. You can ask the patient to come when you think they're going to be going down. You can give them GCSF to cover that. I think Codoxem IVAC is more toxic. I'm not a big fan of huge doses of methotrexate, especially in our setup where we can't measure the methotrexate levels. And so that's the only bit that makes me nervous. But I think there's much more methotrexate in Codoxem IVAC in hypercivard. And R-epoch is very easy to deliver. Dose-adjusted R-epoch is just 5 days in hospital. It's not a big deal, usually well tolerated. But as I say, the toxic effects are felt mostly with arcodoxamivac. The rest, I feel, okay, hypercivard is toxic, but you can mitigate that because you can predict it. And I think a dose-adjusted R-EPOC, in my experience, it's well tolerated. I can't give you long-term data that is meaningful, but none of that is meaningful. Yeah, I can't. But you can read the literature in that regard. But what I can tell you is those drugs are deliverable in a safe way, and your patient can come back for the next cycle. But you need to have transfusion services, and you need to accept the cost of GCSF use. Because if you're giving the patient that toxic therapy, then you have to accept, you have to manage them through the worst part, which is the side effects.
Just another question. How many cycles of EPOCH, R-EPOCH are you giving to your patients?
Six. But 6 cycles. But again, that's dependent on patient response. Yeah. And toxicity, because you can go up to 8.
All right, let me ask our team. So what do we think? Should we do?
I'm going to beg to leave if that's okay.
Thank you very much, Daktari, for your input. That was very helpful.
Okay. All right, thanks.
We hope you can join us another time.
Okay.
Asante.
So what is the cost of an infusion pump?
About
200,000.
Wow.
And it's not reusable?
No, it's reusable.
Yeah. It's reusable. Yeah. So one patient can finish, give to the other like that. We can buy it as a capital item. And then patient, because we don't have many patients. Because in this study, all these patients were being treated as outpatients. They were not being admitted. And I think it was because of the infusion pumps, because then that can be measured and regulated. So we may need to at least buy an infusion pump. And I don't agree with her about using peripheral lines to give people. You'll run in a lot of trouble. You will have so many breaths, and the nurses will not even want to be near that patient because they have to keep looking for it. You know, I found somebody getting Folfox, and they had got a granula, the pediatric granula, the smallest. That's not how to give chemo. So I think, to me, if you ask me, I have had experience with EPOC in the past with about 3 or 4 patients, and all those patients are still alive. They didn't complete the dose because of toxicity and because of inconvenience. It was not dose-adjusted EPOC. It was just EPOC, the way it was, the first generation EPOC. And the patients gave up, because it was too toxic. It was too much for them to tolerate. But they are all still alive. All the 3 are still alive. So I have a feeling EPOC is a much more superior regime to CHOP, which we are using. And for us to use CHOP, I think we are regressing rather than moving forward. Yeah, because there is no guideline that recommends CHOP in Burkitt's lymphoma. In fact, I remember there was a time we were having an NCI meeting on Burkitt's lymphoma in Philadelphia. And the speaker asked, what various people from various countries use for the treatment of Burkitt's lymphoma. And then there is this respected Kenyan, specialist in Burkitt's, professor, who said CHOP, and everybody was stunned in the room. You would see the faces on everybody's room, that in Kenya we use CHOP and it does very well. Of course it doesn't, So that's, so I think we need to look into ways in which we can implement this. But even more important, we need to follow up these patients. We need to have a system of follow-up so that we know exactly what is happening to these patients. We know when to intervene frequently. And we don't have any survivors now with Burkitt's, do we, in our program? It's 0. Sema tu kweli. It's zero, you know. So, I mean, Dr. Jiru, is the patient still alive? She developed good. So how is she now? That's good. Oh, that's from Marilla. Oh, good. Yeah, so that is nice. So that's one. But you
We can't hear what you're saying.
Oh, sorry. I also have a girl from Kisumu who is still alive. Must be about 5 years. She had buckets on the table.
sorry, in Kisumu, do you have any survivors with buckets?
For children, mainly. I've never dealt with adults with Burkitt's lymphoma personally, so I don't know.
I'm also not aware of any survivors from the adult clinic.
And what regime do you use in Kisumu?
For the children, we use CHOP, yeah.
Okay, so that's fine. Any hospital?
Yeah. Or why don't we do like a study on this? I think that would be the best way to go and see, because obviously we are seeing that the number of survivors from CHOP or R-CHOP are quite few. So you can write up maybe a protocol, a study, and do it on maybe like 20 patients, phase 1 or phase 2. I mean phase 2.
I totally agree with Dr. Opakas. And one of the things that impressed me about this study is it had only 30 patients, 30 participants, and it made it to the New England Journal of Medicine. You know, to make it to the New England Journal of Medicine is not a joke. And to make it with only 30% shows us that it's capable. And then this study was intramurally funded. You know, the only external support they received was Phil Graston. Everything else was institutional based. So I think it is possible that we can do this, and I agree with you that I think we'll need to sit down before we can switch, which I think we should, but we need to do it in a protocol-based manner. We need to sit down, draft the protocol, and draft the minimum requirements, and basically do it as just the way they did it, you know, an uncontrolled study. You know, even if we don't have a control arm, that is fine. But if people strongly believe that RCHOP is better, then we can control it with RCHOP. We can have 15 patients on RCHOP and 15 patients on dose-adjusted EPOC, and move on, and then we analyze that after we reach those 15. I think that would be an excellent way to go.
Question, this R-CHOP, I mean, it's already known that R-CHOP doesn't work for buckets, so I don't know how ethically it is right to actually have a control arm where you have R-CHOP. And then the other question is, are we concerned about HIV versus HIV positive as opposed to HIV negative? Because I think there also lies a problem in regards to response and outcomes and how much the patients can tolerate the chemotherapy. So even as we write this protocol, are we just saying 30 buckets, whether you are HIV negative or positive, or could we go further and subcategorize so that we see whether it actually works as well for HIV negative as opposed to HIV positive patients?
I think I agree with you, Dr. Njiru. I don't know why the people in Kisumu are still using RCHOP. I don't know what guidelines they are using, but I think it's important that whatever we do should be in very clear guidelines. And you can check the ESMO and NCCN guideline. There is no RCHOP anywhere for Burkitt's lymphoma. So I would urge anybody treating Burkitt's to stick to guidelines and not just, give chemo without very clear support in terms of literature. And yes, I think what we will do, like just this study did, they recruited every adult who presented with Burkitt's lymphoma, and it turned out that 19 were HIV negative and 11 were HIV positive. We could do the same. I know the question that you're asking is, shall we give both of them the same regime, or shall we be a bit lighter on people with HIV? And I think that is something that we can discuss in the protocol. I think, yes, people with HIV, I think we may need to be lighter. Just the way they did, they gave them fewer cycles, but higher dose of rituximab. The advantage we have now is that NHIF covers rituximab, and we have a lot of biosimilars of rituximab in the market, which bring the cost to about 3,000 per 300 micrograms, which I think makes it. Yeah, filgrastim, yeah, which brings that up. But the rituximab, I don't know. I think, but again, NHF still covers rituximab, although to a limited extent. But yes, it covers rituximab. So if you look at it, given the current atmosphere, we can actually get all these drugs through NHIF, literally all of them. And ours is just to follow the protocol in administration, capture the data, and be able to tell people something about what we are doing with Burkitt's here in the next several years to come.
Well, I think I don't know if anyone else has an input. It seems that we are moving towards embracing this. We are just looking for logistics, how to go about it. Exactly how do we write that protocol? I do clinical work most of the time. As in, how do we go about the writing, and who is like the reference runner? Should we just like okay?
Yeah, I'll do the drafts and then circulate it to everybody who is interested to give their comments.
Another question: would the people in Kisumu be interested?
I know they have.
That's because they do have.
They have numbers.
We have a lot of patients coming back. It's from around there.
So yes, would be interested.
All right. I think we'll leave it at this. In the meantime, we will continue the patients on. I really feel like that should change, but I think we will continue with our chop. Yeah. Now what do we do? Well, we could as well just change and see and mitigate the challenges that we come up with.
Yeah. So this is my suggestion. Yeah. Yes. I think in my view, patients who can and who have the ability to get dose-adjusted epoch should be started on dose-adjusted R-epoch straight away, even as we write this protocol. It does not need to change. I mean, there is obviously no justification to use R-CHOP in Burkitt's lymphoma. It does not appear in any guideline, and there is no need to use it. But dose-adjusted epoch gives you the leeway to reduce the dose to a level where your patients can tolerate. That is the basis of dose adjustment. Yeah, those who can tolerate high dose, you give high dose. Those who can't, you give low dose. That's what it is, and I think that is what we should use, and completely leave out R-CHOP in Burkitt's lymphoma.
All right. I think the clinical team will go and sit down and see those logistics. See how practical it is. Yeah. But I think really we need to change our patients to this. Yeah, good. Thank you very much. If anyone has a topic that they feel we need to put our heads together, you're welcome to bring it up. I think this is like our first lab. Should we like make it a bit more organized? Maybe now outside the could we maybe look at discussing something maybe once a month or twice a month?
Yes, I think this is a fantastic way, and I will nominate Dr. Peace Mbenge to coordinate the journal club and ensure that we can. I think we can do it every Monday morning, just for 30 minutes. After the tumor board, you pick up something. It does not necessarily even have to be a study. My preference is guidelines, so we can always have somebody coming to discuss, the NCCN guidelines on this disease. Okay, we just move on disease by disease, and then everybody can have an opportunity to come and lead the discussion on the current guidelines on that particular disease. So anybody can choose whatever disease they are comfortable with, go to Google, bring out the NCCN guidelines or bring out the ESMO guidelines, and then present it as a journal club. But if somebody also wants to add a journal article, that's fantastic. And my preference would be the guidelines, because once we all know that all the things we do are as a result of these guidelines and not just what we learned in school, then we shall be able to treat patients better.
All right, thank you very much and have a good week.
Okay, bye.
Bye-bye. I think I have many words. Okay, good. One sec.